Good afternoon, everybody, and welcome to our webinar this afternoon on COVID-19. My name is Janet Chapman. I'm the Executive Director of Regional Partnerships and Planning for Albury Wodonga Health. I'd like to thank the Primary Health Network colleagues in the room today who've helped us to pull this together at very short notice and are assisting us with the technology. So thank you very much to Nick Palmer and Carolyn Handley. And with me today is Justin Jackson, who is our infectious diseases specialist for Albury Wodonga Health. I'd just like to commence the proceedings today by welcoming everybody. I would also like to acknowledge the traditional owners of the land on which we're meeting today and pay my respects to elders past, present and future, and extend that respect to any Aboriginal or Torres Strait Islander people who may be present today. So we've got an hour. We hope to have probably at least 10 minutes or so at the end for questions and answers, and also a very small amount of time at the end just for a bit of feedback on this session and any requests or advice about future events. So thank you very much. I'm going to hand over to Justin.
Thanks, Janet. So it's a real pleasure to be here this afternoon and just to really engage with our GPs around this topic. I'll just bring up our first slide. A lot of the early data about this novel coronavirus came from Bruce Aylwood's team, who went to China, and really, I think, firstly, there's a lot of panic and fear about this, but there needs also to be a very measured response. And so I'll come to the severe and critical end of the spectrum in a little bit, but the first point that I'd really like to bring home is that over 80% of infections are mild, and that's something that you'll all be very well aware of. And even taking that a step back, probably the majority of the population will not get infected, and we'll look at that a little bit later in the presentation. It's obviously the severe and critical end of the spectrum that's causing the concern, and we'll discuss that a little bit more as well. Some very brief demographics, because I think most people will be familiar with this information. So from the WHO China report, where they analysed about 56,000 cases, they found that the median age was 51 years. The majority were aged between 30 and 70. It was about 50-50 male and female. And as we're hearing in the media and pertinent to schools, which I've got a little bit of information on later as well, there's a very low attack rate for those under 18. And the children that have been picked up were largely identified through contact tracing in households of adults. Again, coming out of China, and we'll wait for more data to come out from the rest of the world, but the transmission chains were largely occurring in families, and that might be due to the way in which China responded to this infection. But in China, 80% of clusters occurred in families, and the secondary attack rate in households was thought to be about 10%, compared to 1 to 5% of contacts in the community. The typical signs and symptoms, again, this is information that you're probably quite familiar with, but this is focusing on data from China. 90% had fever, 70% dry cough, 40% fatigue. So those were the three predominant symptoms. Just coming down that list, it's important to recognise that occasionally people initially present with nausea or vomiting or diarrhoea, so there can be a gastrointestinal component with that. Just to put that in perspective a little bit though, and I found this diagram from the Imperial College of London very helpful in thinking about this illness. You can see here that they mapped out a number of cases and actually looked at symptom progression and noted that patients often developed the cough and the sore throat first, followed by the fever, and then fatigue, and finally at that point their first consultation, and then hospitalisation where the pneumonia diagnosis was made. So I actually find that diagram helpful because while there will be exceptions and we need to keep those exceptions in mind, I think it's also important to know what's common and really to focus on what's common. And again, just bringing your attention down to the highlighted text, it just reiterates the same point where cases often present with fever and cough, then progress to myalgia and fatigue, and finally on to pneumonia at 5 days following initial symptom onset. And so this particular group had looked at about 170 cases. The risk factors for severe disease are well recognised, and I won't really go into that in detail, just to reiterate that only 0.2% of those under 18 developed critical illness. I think one of the things that really perhaps caught everyone off guard, including me, I must admit, is understanding the exponential nature of the way that things change. And you'll probably be familiar with the story of the chessboard, where 1 grain of rice was doubled to 2, and then 4, and then 8. And it doesn't take very long before the number of grains of rice is very large. Coronavirus is thought to have a 7-day doubling, and so this was just a very simple graph just to remind us of an exponential curve looking at coronavirus, where I've started day 0 with 1 case and then mapped it out for 4 months. And you can see there that there's a long lag period before the cases really start reaching significant numbers. Again, this may be a paper that you're familiar with, but there are some key points that helps inform the public health response. And you can see in blue the date of onset of infection. This information was only known about retrospectively, as the authors of this paper, when they confirmed the diagnosis, went back and asked about symptom onset. And so you can see from this graph that when the official tally was at 100 cases, there was actually 1,500 real new cases on January 21 in China. And again, 3 days later, when there were 400 new cases, the real new cases were about 2,500, again following that exponential curve. And if you add up the blue histogram bars on that date, January 24, you find that there were actually over 10,000 undetected cases in the community. So I think this is important to be aware of, because what we're actually picking up, this is not what we're picking up with our international travellers. This is more when there's community transmission, is the tip of the iceberg. Again, just some important information. When China undertook its measures on January 24 and locked down the city, you found that there was an immediate halt in the rise of true cases, but detected cases took another 5 days before it started falling. There's been a lot of discussion about the different modes of spread, but I think the fact that these measures really halted spread gives credence to the fact that it is largely by droplets. And again, perhaps a little bit simplistic, but droplets can be thought of like rain. They stay in the air for just a very short time, less than a second, and only travel for a few meters. Studies, you may have seen the NEJM paper that just came out today, I think, looking at how long the virus remains viable. And it's probably between 48 to 72 hours, depending on the kind of material or the kind of surface that it's on. But this route of transmission appears perhaps less relevant. Again, it's a changing field and it's hard to know what the data will show over time. But the fact that it is predominantly droplet as opposed to airborne shows why social separation measures have been so effective. This map, again, is something that you're probably familiar with from Johns Hopkins, and you can see when I looked at this on Saturday that the cases around the world in yellow, well, the two things first, the orange part of the graph really shows that the data coming out of China suggests that they've stabilised their cases at a total of 80,000, and that's reassuring. Obviously, the yellow line is the other locations around the world, and as you can see from Saturday to Sunday, and then when I looked again yesterday, that yellow line is certainly heading up on an exponential part of the curve. Case fatality has also been something that's been hotly debated, and it seems like the case fatality rates are really proportional to the population in which the virus is spreading and the rate at which the virus spreads and the preparedness of the healthcare system. So where it's spreading undetected, the healthcare system is unprepared, and the rates seem to be somewhere between 3 to 5%. Where the healthcare system is prepared, it seems to be less than 1%. I just want to now move from the mild end of the spectrum to the severe and critical end, and just think a little bit more about the relevance to our region locally, and think about why healthcare systems collapse. And I'm sure this is something that you've all thought about within your practices, and I'm really thinking about it from the hospital and our experience over the last couple of weeks. So originally we were able to, now we haven't had confirmed cases within Albury Wodonga Health, but originally when patients came to the emergency department, there would be clear epidemiological risk factors. So we would be isolating patients that had international travel or confirmed contact with a case, etc. But and again, there was a recent paper that came out of Italy describing the first case that was admitted there in their healthcare system, and this was on February 20, and this patient was actually in their healthcare system for 5 days. They were a young person, so not fitting the usual demographic, and they were also a community member with no clear links to a known case. And so by the time this case was recognised, the patient had spent a long time in that hospital. There were many contacts within the hospital, but also it indicated that there was must be spread within the Italian community. And so just bringing that back to our local healthcare system, at the moment, patients with respiratory illnesses due to various reasons may spend many hours in the emergency department. When they move to the wards, single rooms are limited, so they may not be put into a single room. The healthcare staff may or may not feel that a test is indicated, and then there's the turnaround time for the testing. So I think this is something that's a limitation of healthcare systems, really not only Australia-wide but worldwide, and speaks to why it's the healthcare system more than the community that's struggling with the effects of this. I think the community is struggling with the economic effects, but the healthcare system is facing a different set of challenges. And then there's really a flow-on effect because our healthcare system is so interlinked with general practice, the ED, the intensive care, the wards, locally with the private hospital and with the practices. And our staff are also linked. And then I guess the third point that I should make there is obviously the community then is very interlinked. If we were to extrapolate from elsewhere and just for round numbers sake, presume that there are 100,000 people in our catchment area. Now there's more than that, but we'll just use that as a round number. On the side of reassurance, we'd find that 60,000 of our community would be uninfected. And in fact, because we're regional and we don't catch trams and buses and other things to work, in fact, that number may be higher. But given I've underestimated our total population, I'll leave that number at 60,000. If that leaves us with 40,000 infected. Of those, only a small percentage, as we saw, require hospitalisation, but that small percentage, given the numbers of infected people, is quite a large number at 2,000. And obviously, if these 2,000 people turn up to our healthcare system within a short space of time, the system would be overwhelmed. And then again, it's unclear what it will be like in our Australian context, but the percentage of ventilated patients requiring ventilation may be somewhere in the vicinity of 400. So these are the numbers that we're worrying about, I guess. So it's the healthcare system that we're worrying about, not the large majority of the population there who will probably be unaffected or mildly affected. Now, this is something that you all will have seen, the concept of flattening the curve so that those numbers can be spread out over a period of time and allow the healthcare system to cope. People have tried to draw on history with the flu epidemic back in 1918, and I've seen lots of comparisons about that. Personally, I don't think it compares because the mortality rate was so much higher and the population which Spanish flu targeted was so much younger. But nonetheless, there are some analogies that we can draw. And certainly two, I think, quite well-known comparisons have been drawn between Philadelphia, where a large public gathering was allowed to go ahead almost 2 weeks after the first case of Spanish flu was detected. And in contrast, another city called St. Louis, where 2 days after the first case was detected, there was rapid measures implemented to try and curtail the response. And the graphs there certainly do represent or highlight that those measures were effective. Now, we'll talk about this a little bit later in the presentation, but it's important to realise that once those measures were lifted, the second population was much more, I should say the St. Louis population was much more susceptible to a second wave of infection. And so that was seen down the track. So I think, yeah, we'll come to another concept in relation to this in a moment as well. So I'm really just highlighting that we've got these three intersecting groups. We've got our healthcare system, the community, and those people with a respiratory illness. Fortunately, the majority of which in Australia at the moment, certainly do not have coronavirus. So I just want to bring it back again even more locally and just ask what will make a difference here in our community, and what message should we be giving people. I think the first message is that we really do need to advocate a rational response and calm the fear and panic that is driving a lot of irrational behaviour. And I've presented the information that the majority will not get infected, and of those who do, 80% will have a mild flu-like illness. Now, certainly, this is putting a lot of stress on healthcare workers, on staff that are associated with healthcare systems, and really, I think it's important just to perhaps take a slight step back. And in a recent email post, there was this comment by Dr. Fiona Stanley, who you'll be aware was Australian of the Year and the plastic surgeon who's done some fantastic work with burns, stated, "Do what you usually do, just do more of it and do it better in a crisis situation." And I think we have a fantastic general practitioner community here, and I think, you know, some of the information that the GPs have been providing me has been more detailed and of better quality than my own research into this. And so I think you're really well-informed group, and you see influenza frequently, you deal with influenza. I think obviously there are specific things that we can do, but I think the first step is that we need to have a really rational approach to what we do. So that would be my first thought. My second thought in relation to that is really empowering the public. And the message to the public needs to be that as a group, they're not at risk from this infection, but they can make a difference in protecting our vulnerable community members and our healthcare system. And I think that really needs to be brought to the fore, that, you know, in a time of panic buying and missing toilet paper rolls, that really what our duty is to be looking out for others at this time. And that's really a key message that I think as healthcare professionals we need to get out to the community. The New South Wales Public Health website has, you know, some good comments on social separation, stopping the spread of infection. But again, I think as a community we need to perhaps be innovative in the way we address what social mixing looks like in regional Australia. And as I've mentioned, we don't travel to work in trams, we don't live in high-rises, and avoiding social mixing might look like taking your family for a bike ride along the river, or helping a mate out on a farm. So very different to perhaps what it looks like overseas. The third thing is just focusing on our healthcare system and perhaps how we can offload that. And so I want to just highlight the Albury Wodonga Health Coronavirus Clinic. This has been operational since the 5th of March, and just today we initiated the drive-through component of it. We've triaged almost 700 phone calls, which is a massive effort in these few weeks to set this up from scratch. And I'd really like to thank the executive team at Albury Wodonga Health for the immense efforts, for our infection control team and many other people that have put a lot of effort into getting this off the ground. And we've swabbed 150 people who met the criteria, which I'll come to on the next slide. And I think this has been invaluable from my perspective. These patients would have turned up at your practices, or they would have turned up at the emergency department. They may well have been infected, and the repercussions in our community may have been significant. So I think 150 people being swabbed is just a fantastic effort. I do just want to highlight as well the role of the clinic. So it is a screening clinic and it's operating within resource constraints. Some of those constraints are national. So we've heard about concerns from swabs and reagents, which I think the swabs are made in Milan. So that's a bit of a challenge with the situation in Italy at the moment. And I understand that the government is, exploring every option for swabs. Obviously, Albury Wodonga Health is still operating to look after the usual patients that we would be caring for at the moment, and we've had to staff this clinic from the resources that are available to us. The other thing that I want to highlight is that it's predominantly a public health tool, and so it's not a screening tool. It's not a screening clinic for the worried well. The public health questions may change over time, but at the moment, these are the 3 questions that we're asking before we really assess their symptoms and so on. So before they get to stage 2, they need to have answered yes to one of these questions. And you see them there and you know them well. Have you travelled overseas in the last 2 weeks? Close contact, or are you a healthcare worker? And so given the large volume of calls, we would appreciate it if your clinics were aware of those 3 questions. If those questions change, we will update you. But at the moment, if the concerned person is not responding yes to one of those, then please divert them away from the hotline. The other area, well, there's a few, but the other area that I think will really help the hospital look after the community and also continue to function and service your patients is focusing on nursing home patients. I guess without being specific, we have had cases that have met definition who have turned up to our facility in quite extreme circumstances and passed away. It's not a pleasant sort of process when you've got people in suits and other things. It's something that if we can look after these people better within the nursing homes, it will make a big difference. So I'd just perhaps like people to think about what inreach into nursing homes looks like, to make sure that advanced care directives are updated, to think about what palliative care capabilities the general practice community have, and careful consideration and notification prior to sending your patients into ED. I'm sure you've spent a lot of time thinking about waiting rooms and looked at telehealth. This was some guidance from the CDC. I'm not familiar with what the GP College has provided, but I'm sure that's something that's been well thought of. The other thing that I've really been asked to highlight from our critical care services at the hospital is that we may need additional capacity, and so the hospitals put out expression of interest if we were to need additional capacity from GPs to work in the more acute setting, whether people would be interested, and if you're able to approach our HR team if that is possible. In the interest of time, I'll let you look at this in the PowerPoint that'll be sent out. But it's really just highlighting, as we change, as the United States has changed from containment to mitigation, that there are some changes around the public health measures and the things that they're able to implement. School closures, I won't talk about too much, but it's been thought about quite a bit, and I would certainly support the comment on the Victorian Department of Health's website. Just in wrapping up, I think that one of the biggest challenges with this is that what we're really aiming to do is protect a small percentage of the population and protect our hospital, really, and that's being balanced against quite significant economic and social cost. And in order to make rational decisions, we need to know exactly where we sit on the curve, because if we're far to the left, implementing massive community shutdown measures will not achieve anything except social and economic disruption, and then just postpone the peak of infection. Whereas if we're sitting where the curve is rising up to the right, then certainly those measures will be of benefit and need to be implemented. And that's something that certainly there's a lot of people working on with more detailed information than we have available. So just in summary, before I move to questions, I think that community intervention measures have the potential to really positively or negatively impact on the healthcare system. The nature, timing and duration of the intervention measures is a difficult decision. And I think that things that are aimed at social gathering of adults and older people are most likely to have the best impact for this particular virus. And finally, this is a team effort, and so I really appreciate your time, and certainly more than happy for suggestions, questions, comments, improvements in what we're doing, because I think that as a healthcare system, we sink or swim with this together. So thank you very much.